edition of our usual virtual seminars. Today we are looking at schizophrenia, balancing our beliefs and appropriate knowledge to manage the condition. As we all know, that schizophrenia is a very disturbing condition. It's a condition that impairs the social, the occupational, the educational life, in fact, the daily life of a person living with that condition. It's a highly stigmatized condition, and these individuals are discriminated against often to the extent that family members, even when they've taken them to seek for treatment, they abandon them. What is the problem that we have at our hands today? Some years ago, a group of researchers, McGrath and his colleagues, were able to point the prevalence of the incidence, in fact, that for every 100,000 people, you would have 15.2 individuals to experience schizophrenia. That is 2008 down the line. So considering development, scientific development over the years, you expect it to reduce. So if you're using our current population projection, you expect that we would have just over 5,000 individuals experiencing schizophrenia. That is not the case. WHO 2007 also projected that depression was about 10% of the population and schizophrenia was about 3% of the population. It's the reverse now. Schizophrenia is leading the pack. Let me show you a graph, and we would continue. When you look at the graph, in 2019, we have females for the blue one. Females, 10,385. Males, 9,359 in 2019. Females more than males. Similarly, in 2020, females 10,470, males 9,386, a total of 19,856. Just last year, females 10,946, males 9,809, a total of 20,755. So you can see that it's projecting, it's increasing. So if in 2008, it should have been less than 5,000, and currently it's over 20,000. This has implications for our health policy. It has implications for interventions. It has implications for everything. It has economic costs. So that this program is meant to educate us to understand what we can do with regards to the beliefs that we have towards this condition and appropriate knowledge, how to balance the two so that we'll be able to help ourselves, help our friends, and help our family. So that at the end of the day, I have two good experts with us today. Dr. Yenisom Maluk, he is a specialist psychiatrist at the Pantan Hospital. Dr. Maluk, can we hear you?
Yes, please, Dr. Atta.
Thank you very much. We have also with him Dr. Erica Dixon. She is also a physician. clinical psychologist, head of psychology at the department, at the therapy and wellness department at the 37 Military Hospital. They are going to support us to understand the issues at hand. We have certain beliefs and we use these beliefs in the management of this condition, in terms of seeking for treatment, in terms of supporting these individuals and all that. They are experts. I'll let them do the talking. The format today, oh, there is Dr. Erica Dixon. Dr. Erica Dixon,
hello.
Say hello.
Hello.
Hi, nice to see you again.
Thank you very much.
So there we have it. We have the projections as at 2019 to 2021. For me, it's scary. Because we're expecting that schizophrenia will be low down the ladder, but now it's leading the pack. For those, we are expecting that at the end of the day, we would understand how this condition comes about, the risk factors, how to seek for treatment, what goes into the management of this condition, and how to balance the beliefs. So we are good to go, right?
Yes, sir.
Good. So we are going to do a question and answer session along the line. We'll ask some from our participants if they do have any, because I have a tall list of questions. I wonder if we'll be able to finish it, but let's see how it goes. Let me start with you, Dr. Maluk. Briefly tell us, what are the common signs and symptoms of schizophrenia?
Yeah, Dr. Ada, thank you very much, and good afternoon to all of you participants. I've seen that we have close to 90 participants, which is good, and we have been on time. Schizophrenia is a mental disorder that we all agree. It's one of a group of disorders we call psychotic disorders, and it affects a person in terms of the person's thinking, the person's affect, the person's perception, behavior, and then the will to do things. When I say thinking, what do I mean by that? Our thinking processes can be affected in terms of certain beliefs that a person may have, which may not be true, but the person holds on to it. For the experts, we call it delusion. Can affect the person's affect. What is an affect? I mean, essentially, your observed emotional expression. They may not even show emotions. Sometimes may not be responsive when you are talking to the person. Behavior, some may be agitated, and coming to the perception. Perception essentially means that how you perceive things, your senses. So if there are disturbances in your perception, you tend to have that. Instead of hearing when somebody is talking, you will be hearing voices or hearing sounds when there's actually no stimuli or nobody making such sounds. Seeing things when there's nobody there. We call these disturbance perceptions as hallucinations. Of course, we also have illusion, but that's at a different level that we'll explain that. So essentially, schizophrenia can present with some of these symptoms, and it presents in early adulthood, usually in your late teens going to early adulthood. And this can impair a person's ability to acquire a livelihood, because it means that you will not be able to complete school, you may not be able to get employment, and eventually you cannot acquire a livelihood. And this connotes, it affects your life eventually. And it comes with it a heavy burden on the carers. So these are my initial remarks about schizophrenia. Then I'll take it up from there when you ask more questions.
Very much, Dr. Maluk. Erica,
hello.
You've seen the prevalence.
Yes.
Let me ask a two-double question. What do you think might account for this, and of what significance is this to us all, even as family members or community? Let's come as family members, as community members. Of what do you think?
All right. I would like to say that worldwide, we know that some mental health problems are common. The commonest being anxiety, and then depression. And on a global front, schizophrenia would not be counted as a very common mental disorder. I'm looking at this graph, and I believe that presently there are a lot of mental health units in most primary care facilities. And soon as people hear mental health facility or a unit, they would usually report more severe mental health disorders to these stations, whilst the common mental health problems like anxiety and depression may get lost in your usual primary care facility. I believe this may account for these numbers that we are seeing. If we are looking at it in comparative terms, I have no doubt that the depressions and anxieties would definitely overpower these numbers if we are doing the diagnosis correctly. That said, these numbers are still worrying that there is such increase. One of the, well, we haven't talked about causes yet, but we know that schizophrenia, like most mental health illnesses, does not have a single reason for which you would get it. For example, if you had malaria, you know that a mosquito bites you and spits parasites in you, and then you develop the disease. But for most mental health diseases, it is a multiplicity of factors, risk factors that come together that would cause a manifestation. One of it is the genes. So there are genetic factors involved here, and then there are the environmental factors. And I think what I would want to hammer on are the environmental factors. Dr. Malong mentioned the fact that the disease would usually start in late adolescent, early adulthood, thereabouts. And we on the ground have seen that a lot of our young folks are dabbling in all sorts of substances that can provoke psychosis from showing up. There are cannabis, there are all kinds of substances that are being used and abused. So these may be part of the reasons, besides the already mentioned factor that the reportage may be the reason why we're seeing this trend, but also the use of substances. Plus, the stresses are high. I mean, most Ghanaians now are complaining of one thing or the other. And we know that where you already have a genetic predisposition, then some of these life stresses may become trigger factors that can push you over the edge. So there are a multiplicity of factors. I believe strongly that these statistics may reflect reportage, but in addition, that the environmental milieu that we are in now is also fueling this a great deal. Yes, Dr. Arthur. Yes. So that is my submission as far as this increase is concerned.
Well, thank you very much. I couldn't agree with you more, because I also, looking at the chart, I said, everybody is hiding behind stress. And this stress is more or less like depression itself. So if we were to apply a validated questionnaire, we would have lots of them, and people are not seeking for treatment, are not reporting them and all that. But schizophrenia, from the symptoms that you just listed, I mean, it's visible when somebody is hallucinating or making delusions about people or places and all that, we can easily tell. All right, so I think that might have accounted for these figures. Itself is still worrying. If we really know what depression, the stakes of depression, then our worry would increase. But it's schizophrenia today, so let's see how that goes. You briefly mentioned, Erica, what some of the underlying causes are. Dr. Maluk, would you like to add something to it?
Okay, thank you very much. So like my co-panelist alluded to, science or research has not been able to say that this is the exact cause of schizophrenia. So, but that's one of the often asked questions when clients and their relatives come for review on the ward, when we invite the families for discussion. Doctor, what caused it? And I'm sure we shall come to the beliefs. And you hear certain suggestions here and there. But having said that, in as much as we don't know the exact cause, but we know there are certain risk factors, biological risk factors and psychosocial risk factors. Let's go over the biological risk factors. Research has shown that, and there have been a number of studies, let's have the genetic studies, where when you have an identical twin, monozygotic twins, whereby they're from the same egg, almost 99% genetic makeup, and one person has got schizophrenia, there's about a 60 to 40% concordance rate. That means that the other twin, whether the person living in the same environment or different environment, has got about a 60 to 40% chance or 40-60% chance of developing schizophrenia. Unlike the general population, that it would be like about 1%. You look at first degree relatives like brother, sister, cousin, that's about 5 to 10%. So it means that there might be a role of genes in this, in the causation. But let me repeat, no one factor can be solely responsible. There have also been adoption studies done, which has also proven the fact that genes can play a role in terms of the causation of schizophrenia. There have also been some other biochemical theories that have been proposed that people have suggested that might be due to imbalance of chemicals in the brain. And these chemicals are the neurotransmitters. For my students that I teach, you know neurotransmitters, we have the monoamines, dopamine, is one of the implicated neurotransmitters. It's believed that dopamine over activity, these are theories, could be implicated. And why do we say so? For people who abuse substances like cocaine, which tends to cause an increased level of dopamine in the brain, you realize that people tend to become psychotic or present with psychotic symptoms like hallucinations. So that's where the belief stems from. But there can also be other psychosocial factors that could contribute to the development of schizophrenia. There have been certain theories that have been suggested that poverty could be a contributing factor. And at some point, they even, wonder whether it was schizophrenia that is the poverty or the poverty that rather causes it. Other psychosocial factors that could predispose or precipitate schizophrenia could be life stresses. Things are hard, marriage problems, etc., etc. That could precipitate it in somebody who has a vulnerability. A vulnerability simply means that an inherited predisposition to develop a particular condition. Let's say you have family history, etc., etc. So, in a nutshell, there is no one cause for schizophrenia, but it's an interplay of the biological, psychological, and social factors. You can say the genes and then the environment coming together to cause the condition.
All right, thank you very much.
Dr. Accra, if you don't mind, may I add on also that there has been some research that shows that even pregnancy and birth complications may be some of the factors that would make a person predisposed. So if you're pregnant, you're not eating well, malnutrition, in utero, babies that are born that are not getting enough or adequate nutrition. So like my co-panelist has said, the poverty issue, if you don't have enough, you're not feeding your child well, it could lead to this predisposition, and then delivery and its complications that may happen. Even some viral infections, especially during pregnancy, can complicate things, and then the brain structures are changed and therefore leaves you predisposed. So yes, all of these factors can come together and leave one person quite vulnerable to getting this disorder.
Great, thank you for that addition. Let me also add that when the father is even old, there is also some risk factor to that. When the father of the unborn child is also old, research has also indicated that that is also another factor. And toxic materials within the environment and all of that contributes to this. So now that we've gotten a clear picture of what schizophrenia looks like, what the causative factors are, now let's come to your consulting room. Erica, how does somebody present schizophrenia when they come to your consulting room? Is that different from what we are saying, or you have to deduce from it? How do they present it? I want to know that from the psychologist point of view, and then I'll come to the psychiatrist.
Sure.
Dr. Malok, if it's same, then we'll keep it as that. So let's hear, Erica.
Yes, I mean, psychiatrists, psychologists are all mental health professionals.
That's
and
right.
We are all looking out for the same thing. Good. So my co-panelists did mention some. A person may hold on steadfastly to certain beliefs that are actually false, but you cannot shake this off. You know, that person believes strongly in what they believe in, if we should say. So they may believe that somebody is harassing them, persecuting them, somebody is spying on them. They believe that some pole that is in their neighborhood or in front of their house is transmitting information out of their head, and so on and so forth. So these we call delusions, where the person holds that, or sometimes they have these grandiose ideas. I am Jesus Christ, or I am the president of Ghana, or I am Putin. They strongly believe this, and you can't shake them off. So in the consulting room, we are looking out for, if we think it's schizophrenia, for these delusions. And apart from the delusions, again, Dr. mentioned hallucinations. The perceptions they have, we all have these senses to see, to feel, to smell, sense of touch, and all of these. And the perception of these senses make a shift. So the person may see, there may be nothing present, but he sees an army of whatever moving along, and you can't see it. Really, there's no need you're arguing that I don't see anything. They see it. This is their perception, and you must understand what is going on with them. And then their speech may be very disorganized because their thoughts become disorganized. They are talking about this, and then they move into another area. You ask a question, and in answering, they may start off well and end up somewhere else. Then you know that, I mean, we express our thoughts, you know, through speech or verbalizing. And so when you notice this, then you know that, oh, something is wrong here. So that's another thing that you may be looking out for. Then behavior-wise, there may be some disorganized behavior. Let me say here that a lot of people have misperception that if somebody has schizophrenia, then they are going to be violent. You know, I think the violence rather comes from people who deem themselves well against the people that we perceive them as not being well. Many people may be sick with schizophrenia, but they are not violent. They may be a little agitated, you know, especially you're arguing about them. I have seen this, I'm telling you, and you're telling me you don't see it. That's where they get distressed. They may feel frustrated, they may get distressed and get aggressive. But on the whole, they are not always aggressive like that. And then there are these negative symptoms that they may feel as far as their mood is concerned. So they may feel down, they may feel amotivated, they don't have that sense of drive, they don't want to mix with people. So their social skills are impacted. For the same reason, they may not be going to work. So the person hasn't been to work in days or even weeks, or they are not engaging with other people. So these are some of the things that you are looking out for. But besides that, over time, you realize that there are some cognitive deficits as well. The way they think, how sharp they were before they started, that changes. They can't remember things the way they used to. So it is a pretty devastating illness when one has it. and it can affect so many areas. And it is the impact of these changes that happen that tends to impact the person's livelihood and quality of life. Their day-to-day is affected. So simple tasks become very difficult. They are not able to work, or if they are in school, they are not able to cope with schoolwork. And we all know how work is important in anyone's life. This really sets the person back and potentially makes them poor. They are not as productive as they could have been, because these are young adults in the prime of their time that should be fruitful, multiplying, contributing to their community. And then all of a sudden, this illness hits and changes that for them. So these are some of the things that we'll look out for in a consulting room to be able to assess properly and offer the appropriate management for the individual.
Thank you very much, Erica. I mean, I think on this occasion, all of us here would now be able to pick out subtle signs that we would use to advise somebody, because we can look out for the hallucination, we can look out for the delusions, we can look out for the cognitive impairment, we can look out for the behavioral rules that are not proper, emotions, and all that. Thank you very much. That's good. So Maluk.
Yes.
Before I come to you, ladies and gentlemen, feel free to insert your comments and your questions. If there's the time, I would read them for our panelists to respond to that. So, Dr. Maluk, so generally, what beliefs do people have about schizophrenia that they bring into the consulting room?
Okay, so thank you. Before I go, let me just talk a bit about the presentation to the consulting room. I'm happy that she did speak about the negative symptoms, whereby they have the lack of drive, the poverty of speech, not interested in doing anything at all. It is not as if they are depressed or anything, but just lack of drive. Beliefs that people bring to the consulting room. Once I had noticed that I was going to be involved in this presentation, I started doing some form of basic research, whereby when clients come, I'll try to note down certain beliefs that they espouse, including their family members, But commonly, some of the beliefs, and these are not just people low standing, but even high standing, So I started noting some of them down. Some of the beliefs that they come with, that they believe the condition is caused by a particular place that the person probably works or lives. So I'll give you, and I know some also believe that it's gotten from a school that family might have advised you that don't go, and then you go and then you develop it. So I'll just share with you one anecdote to make this point. A gentleman was, when we invited him for a discussion, and because the daughter was doing well. And then when I was trying to understand what he thinks about the beliefs, what he thinks about schizophrenia causation, he said, "Doctor, I know it is from the school that my daughter went to, because I told her not to go, and she went and she came back with the illness." So some of the beliefs that it is due to a particular place that the family thinks that the person should have been to. Some also believe that it is spiritual, that this could have been due to a spiritual attack, or maybe a spiritual group that you've engaged in, then probably that's where somebody has attacked you. Some also believe that a person presenting with symptoms of schizophrenia, or somebody who has diagnosed as schizophrenia, somebody who has schizophrenia, is stubborn. They don't even appreciate that the person probably has a mental condition, needs help, and needs to be treated. So the whole belief is that this person is stubborn, doesn't want to cooperate, Let me talk about a final belief, Some also believe that it is due to marriage, or that, my daughter or my family member was one, he or she went into marriage and then came down with schizophrenia. So these beliefs have to do more of the etiology or causation, because people attribute some of these things as the causes of it. Let me just quickly add to your earlier question to Dr. Dixon about the presentation in the consulting room. sometimes the presentation or the symptoms of schizophrenia at the beginning, they are vague and non-specific. We call it prodromal phase. So families may not really place so much premium, even though they may be concerned about, oh, maybe because he's a teenager, you know, or a university student, so probably that's why. So it's certain odd behaviors like maybe pacing at night, adopting certain postures, you know, that the family may not really place so much premium on. But over the period, when things are increasingly becoming worse, the person is no more sleeping, the person begins to talk off point, etc., then they now become worried and then they present you. One key thing that we usually note in the consulting when we are taking the history is that decline in academic performance usually helps us to know when the symptoms probably started. For instance, somebody who is in senior high school third year, after hearing voices talking to him or her, either directly or through in the third person, like being spoken about. And that's one that this may be odd to the person, but the person may not really open up because the fear of being labeled that, hey, there's something wrong with you. And this would affect the person's studies. Eventually, the person may not even perform well, you know, but the family may not even know unless the person opens up until things begin getting worse, whereby manifesting the person's behavior or speech, then they begin to take action. I think I would, yeah. Dr. Anta, over to you.
Yeah.
That's quite interesting. With regards to the beliefs, Erica, would you like to add something to it? And I want you to tie it to whether this belief is as a result of, what do I say, globalization or socio-cultural factors. Is this a recent development or it's been there historically? Put the two together for me.
All right. I think that one of the beliefs maybe some of what we've talked about, the fact that some people believe that it is passed on in the family, you know, that, oh, this person is showing the image, is there is some truth in there, as we have already said. But a lot of people show belief in spirituality, they spiritualize it, you know, and I think that is very cultural. For our culture, I can assure you that we tie everything to culture. I did a study on strokes, and even for stroke, people know the risk factors, hypertension, diabetes, that, but they'll say, in my case, it is spiritual. And so for mental health problems where there's very little understanding of what is going on, it's not surprising at all that often people believe that this person has done wrong to another person, that's why they are being punished, or somebody has cursed them, or anything along those lines. Some malevolent spirit is against this person. But Ghana is one of those countries that we've been shown to be very spiritual. Everybody subscribes to one religion or the other. And we interpret a lot of what goes on with us in that spiritual lens. The good news is that there is real treatment that can be given. And going forward, we really need to educate people so that they come to recognize that, like you would have hypertension, like you would have diabetes, these may be long-term illness or chronic illness, but they are treatable and people can live with it for a very, very long time. Also, and falsely so, we have said that, yes, sometimes it is a factor. But people would see anyone who has a psychosis and conclude that that person is using substance, which is not true in every case. These may be provoking or triggers, but it doesn't necessarily mean that everybody you see that is showing signs of schizophrenia is an addict or abuses substances. So these are some of the beliefs, besides what Doc has mentioned, that people propagate when we encounter them. And I think that these stem from the fact that worldwide, and I emphasize on worldwide, the understanding of mental health is really low, maybe especially low in our context. But many people don't have the clear understanding of mental health problems, and therefore they postulate all kinds of myths and beliefs to try to bring some level of understanding to it.
Thank you very much. I mean, that is the purpose of this seminar, and to have specialists like you on board to educate the public. I mean, we have 110 participants here, which is quite encouraging. Dr. Maluk himself yesterday was also on another program with Coco Clinic doing similar exercise. So yes, we are fighting a strong battle here, but eventually we'll get there. So far, the only question that has come in is, why are more females affected? Considering that we've mentioned that there are substance abuses and all that, but there is one question. I've noted it down, but I'll come back to it. I want us to get into the management and treatment. I mean, now we understand what the causes, what the basic beliefs, the spirituality behind it, and all that. Let's get into the management. Dr. Maluk, what goes into the management and treatment of a person with schizophrenia?
Okay, thank you very much. This is very important aspect of it, management. So in talking about the management, I'll first look at in terms of how we diagnose the condition. And after diagnosis, we then go ahead to treat. So not to bore you, let's assume that we've done the appropriate assessment, we made a diagnosis, make sure that this person really has schizophrenia. Then we then go ahead to treat. So the management would involve the bio-psychosocial approach. This an approach which should actually be applied to virtually all conditions in the world, all ICD conditions, and not just mental health conditions, whereby we look at the biological treatment involving medications, the psychological treatment involving the clinical psychology and other psychotherapeutic techniques, and the social treatment where we look at social interventions that we can put to help the person to get well. The biological treatment usually would give antipsychotics. We have various forms of antipsychotics are medications we use in psychiatric settings that are used to treat the psychotic symptoms we've spoken about, the delusions, the hallucinations, the odd behaviors. The psychological treatment, I'm sure Dr. Dixon will speak about that. Then the social treatment. So let me talk briefly about the psychosocial treatment as a whole. We need to provide some form of psychoeducation to their families too. So aside just putting them on antipsychotic medications, they need to understand what is happening to their family member, or the person needs to understand, though the person may not have insight, but you've got to explain to them that this is what is happening. The person needs to be on treatment, needs to be on medications, and perhaps talk about the side effects of the medications, and they need for the person to adhere to the treatment that you've agreed that you are providing, also to come for schedule review. The person is going to go on, is going to an OPD basis, and be ready to take questions from them. You know, aside that too, you also need to counsel their family to appreciate that this condition that is starting, it is not just a one-day thing. You know, the family need to provide the support. It may be stressful, but once they have the knowledge, you'll better be able to manage to help support the client. Because as I don't know that shall come to that, but families that have a family member with schizophrenia, it tends to be this level of stress in the family, and leads to what we call high express emotions. You know, yeah. So essentially, let me end here with the management, and then yeah, if Dr. Dixon has something.
Okay, yes, right. Definitely. Erica will ask some. Erica, please make it so simple and nice to attract people to seek for management and treatment. Let them not think that it is rocket science. That it's not doable.
Dr. Atta, let me just add something before Dr. Dixon comes in. Let me state that. Let me just make a point that we work hand in hand with a clinical psychologist.
Okay. Yes.
You know, and yeah.
Yes.
Thank you very much. Yes. The treatment is not rocket science, indeed.
No.
I always like to make analogy between physical health issues and mental health issues. I think it helps people understand. If you were diagnosed with an illness like hypertension or diabetes, you know that you'll be on medication for a long time. All of us hate medication. I don't know who really loves taking medication. And therefore, when you are put on medicine that you have to take for a very long time, it's really difficult. So explaining why it is important for that individual to continue taking the medication becomes key. If you see the kind of disruption that this illness can bring in your life and in the life of loved ones, and you have that clear understanding, it becomes easier, you know, to want to continue taking the medications because you anticipate that the sort of disruption that could happen is too costly. And therefore, sticking with your medication becomes more cost effective. And so having some adherence counseling, first of all, psychoeducation, not only for the person who is suffering the illness or experiencing the illness, but their significant others becomes key. Then everybody understands, because when those who are close don't have clear understanding, their behavior or response to the individual who is in this situation can become triggers and even make the condition worse. So it's important that the education is clear for all these stakeholders. And then some adherence counseling. You know, you may start off, you're doing well, and why must I continue taking medicines when I don't feel sick? So continually going for your reviews, checkups, engaging with the psychologist, engaging with the psychiatrist, you get that motivation to keep going on. We have mentioned that some of the deficits that happen involve the person's social abilities. So some social skills training may become necessary. These are young, relatively young people who are now engaging with life. Then they are thrown off balance like this. Sometimes they are not even sure what is going on with them and how to handle certain things becomes overwhelming. They may need to be taught certain simple interactions, even including if you meet somebody, how do you make a friend? How do you spark off conversation? Because management of schizophrenia now is not just about taking away symptoms, but it is about the person having a good quality of life, recovery in all these areas that there are deficits. So social skills training, some cognitive interventions may be necessary to help them bridge these cognitive deficits that they have. So there are some apps and so on that they may use to help them sharpen their thought processes. I'm sorry, can those who have unmuted mute so that we can all hear each other? Thank you very much. So medications are only one aspect, but some psychological interventions, including psychotherapy. Now, there's something called cognitive behavior therapy, which a lot of people know about, but this has been developed also, cognitive behavior therapy for psychosis, where the thought patterns that we mentioned, how skewed these thought patterns are, the therapist helps this person to rephrase some of these thoughts such that they are able to function better than they would have if these thoughts haven't been chipped off a bit, haven't been smoothened on the edges, as is done in therapy. So these are some of the interventions. In other jurisdictions, people are helped to find jobs because working in itself is therapeutic. You're feeling useful. I don't think that has come in here in Ghana, and most people don't understand. So if you try to find a job for this person, but then you can do a skills training or vocational training for this person to be able to acquire some skill, to be able to be to find a career or be productive for themselves. And additionally, besides trying to give them social skills, psychotherapy to reshape their thoughts and thinking, cognitive interventions, and then looking for employment. I think that since this topic is up, we need to encourage labor organizations to do workplace mental health policies. If somebody is working and develops a mental health problem, you shouldn't kick this person out. You should seek all the support that they need to get them well. And if it means that you need to change your job role, you know, to make it easier for them, and then they come back to take their job role when they are feeling better, why not? So these are some of the interventions that are helpful in addition to the medications for persons who are living with schizophrenia and their families. Management does not leave out families because they are constantly with them. And when they are stressed, like Doc mentioned, they tend to aggravate or agitate the person living with the disease. And they themselves begin to develop other mental health problems, being stressed, adjustment difficulties, so on and so forth. So we need to give this holistic care to our clients and their family or significant others. Dr. Atta, I hope this was simple enough.
Oh my goodness. Well, it was simple enough because if you had gone the rocket science path, you wouldn't have finished now. So I think it's simple enough. Yes, you mentioned workplace mental health policies and all. In fact, I am thinking that if most workplaces have this policy, issues about mental health, the prevalence and all that would most likely reduce, because I mean there are no policies, so everybody is afraid of declaring their mental health status. People are playing presenteeism, absenteeism, and all that just to avoid some of these issues. But workplace mental health is also another topic for another day. Talking about beliefs and talking about management. Dr. Maluk, has there been occasions that the religious beliefs of the individual, the family come into play when you have to manage this condition?
Absolutely.
All the time.
And this is not once or twice or thrice, several times or multiple times. I mean, you see, it is understandable looking at the settings in which we find ourselves, whereby, I mean, we are spiritual beings, that is one, and Ghanaians, we try to spiritualize several things. So yeah, there have been several examples, but usually our job, especially my team, we try to engage the family to let them appreciate the fact that the person, as at now, came to admission, or as the person is present, needs the treatment. You can pray, you can do it, but taking the person off the treatment or off the ward wouldn't help. So I'll just give some few examples. There have been times that, let's say, one member of the family, so let's say if the spouse is the one who has a condition and is on admission, the extended family of the one who is on admission will believe that, okay, look, our family member cannot have a problem. So please discharge our family member to us and we'll go and seek for spiritual help. So some would even come on the blind side of the one who brought the client for admission. And usually what we do is that we invite all of them together, we sit down and we explain to them. And on most occasions, it has yielded positive results that they all then agree that, look, let's give it a try, let's see how it goes. And then they now begin to appreciate what's happening. And usually once the patient gets well, we then let the clinical psychologist also meet them for family therapy. And it has worked on most occasions. Of course, there have been some few ones that we just have to, okay, write the strategic medical advice and then we let them go. Let me share another case in point, which I'm out of time now, you know, but it was just about 2 or so weeks before I traveled out of town. This gentleman woke up one day and said he had a dream about a cousin that he hadn't gotten in touch with for over 10 years. But I had a dream about her, and that was his baby. So he said that he was going to look for her. And looking for this lady, he found out that she had deteriorated in so, you know, so he took it upon himself to get her to the hospital with the help of someone who knows her. Family later gets to know about this and said, discharge her to us. We don't think that this is a physical condition. This is something that, you know, needs hospital treatment. We invited the family and we engaged, and they agreed that, okay, so they would allow the client to, for some time, see whether the client will get through. And the client said show improvement. So I'm out of time. I don't know whether my team members have discharged the patient or not. You know, so there have been several times that this has happened, but you've got to understand the belief system and work around that to provide the care.
Just to add on to that, I
know you definitely must add something to it, Erica. I know.
We know that
go ahead.
Health-seeking behaviors is often informed by people's beliefs. So if they have no clear understanding of what is causing this, or if their belief is that this is being caused by a spiritual matter, of course, their health-seeking will take them for spiritual intervention. Personally, I tell most of my clients that thankfully, prayer on its own has no side effects, and therefore it shouldn't hinder anything at all. Members of the family can go ahead and pray whilst this person continues to take medications. And you realize that if that's happening, it satisfies both belief systems. We believe that the medications and psychotherapy, all of this is working. They are praying alongside. It goes well. This is our cultural context, and all of that must be factored into the care of the individuals. It only becomes a problem where sometimes they are taken out of hospital, they are put off their medication, and then they end up in, I'm not tagging at any particular religion, but say a prayer camp. I have had such an experience where a church member who was in my group, I found out she was ill, and they said she was in a camp somewhere. And we went to visit. She was in shackles, and they had beaten her because she had resisted some of what they were doing for her. And it was very painful to watch. We managed to get her released, to be brought to the hospital, admitted, had treatment, and doing very well. So sometimes these become an obstacle. The belief system become an obstacle in the person getting the best possible care. But we should have this in mind and engage all parties to understand that both can go concurrently. And I know that there are some projects going on in some of the prayer camps where persons who are in the camps are receiving care. They're getting their psychotherapy, psychotropic medications. They are being engaged by mental health staff to give them the necessary psychosocial inputs there. So if this is our context, we should see how best to be able to harness all of it and get the best outcome for our clients.
Thank you very much, Erica. In actual fact, I think Dr. Ursula Reed and some mental health professionals in Kranza, thereabouts, are doing a project with traditional and faith-based healers. After engaging with them, when the family goes to these practitioners, they tell them, okay, no problem, go for the medication. When you are done, come and let us pray. And in fact, results shows that the recovery rate was much faster.
Yes.
Was much faster. So
I think a similar one is going on up the mountains at Mampo. So it is great.
Yes. So, ladies and gentlemen, I mean, encourage people that yes, the religious beliefs, fine, but we need to balance the two. We need to balance the two. I think I have one more question. Then I would allow our participants to also ask some questions. In actual fact, they've sent in quite a lot. Quite a lot. I wonder if we can do justice to all of them, because I have not even exhausted. So now, Maluk, with regards to seeking for help, because I want us to clear this one before other questions comes in, but with regards to seeking for help, balancing the beliefs and the appropriate knowledge that you have shared here, what message are you taking out there? Erica will also respond to the same thing. Then I'll come back to the questions from the participants. So Maluk, have it.
Yes. I think my key message to everyone is schizophrenia is treatable. It is treatable. We have our belief systems. Nobody can take that away from us. But we should also appreciate the fact that the condition is treatable, and we can work within the belief system to seek for the appropriate treatment. And I keep telling clients that, and family members, that God has given us the knowledge for us to be able to make the diagnosis, and for people to be able to make certain medication that was gotten from these plants and herbs that you'll be going to, to tease out the exact amount you need for the treatment, and we put you on the treatment. So whatever with the hospital settings, whether the psychosocial aspect or the biological, the medication aspect, it is based on evidence. And it's also God who has given us that knowledge. So my point is, it is treatable. Let us all seek for help when we realize that our client has got a condition, in this case, schizophrenia.
Yes, to add on, I support you fully that this is a treatable condition. If you believe it's spiritual, it is God that gives knowledge or wisdom to humans to be able to work. Seek professional help. And these days, there are mental health units everywhere around the country.
Right.
If you are not sure, go first to your regular physician or your primary care physician. Take the person there. They will start something. They'll refer to the closest possible facility so that you can get the best possible care that you want. And then you'll be able to go ahead and serve your God the way you want to be able to do.
But try to also watch order. But
all right. We muted them now. So yes, I think that at the end of today, what we should go out or away with is not to be frightened about people who have this illness, to know that there is help for them out there in many different spaces, and to support them as best as you can in seeking the help. That's my 2 words.
Thank you very much, Erica. Don't worry, let your belief be, seek for support from the medical facility, and as an individual, provide that psychosocial support. You know, so.
It be so.
Thank you very much. Okay, now I have a few questions from our participants here. I have not exhausted mine, but it's proper that I go through some of them. The first one, well, according to my table, most females are those who were affected. Why is it so? We have any idea why it's so? Because we thought that it's all about drugs and all that, but now, why? Do you have any idea why more females?
Let me hazard an explanation.
Okay.
Again, we know that globally there are more men that experience schizophrenia than females. Our particular trend is a little out of different from what the global picture is. That said, I believe that our women seek medical care more than the men do. So this may probably be accounting for this skew that we are seeing, that we cannot say, per all the evidence that exists, we wouldn't be able to say that more females than men get schizophrenia. The reverse is actually what is true. But we are seeing a pattern that more women are reporting with schizophrenia than men. And I think the reason is just in the reportage rather than the actual prevalence rate.
I couldn't agree with you more, Erica. I couldn't agree. I think that it's an issue of reportage. Yeah. One other question says, can you please throw more light on why men who give birth late in life causes schizophrenia? It's not because he gives birth late in life, automatically the offspring would have schizophrenia. No, there is a certain minute percentage. Even if it is 0.05, it's still a chance. So that's what it is. Unless Dr. Maluk, you want to add something to what I've just said.
Oh, I mean, absolutely. Like we earlier on alluded to, there's no exact cause, and increasing or later age of trying to give birth could be part of the some of the risk factors, more biological or psychosocial, risk factor. That is what it is. It doesn't mean that the fact that you are giving birth late, you necessarily would give birth to a child who has schizophrenia.
Yeah.
I have an interesting question here. Mm-hmm. Why is one quickly brought to the mental hospital if significant others realize the person is aggressive as a result of substance abuse, but same relatives are slow to act if the person starts preaching until he or she is not able to maintain his personal hygiene or is noted to be unkept before he's sent to seek treatment? Why is it so? But I think it's all about those beliefs. I don't know, Erica, I don't know what you
Yeah, I believe, I agree with you that it is the beliefs. I mean, when the belief out there is that people who do substances can get mental illness. So when they see that, then they obviously think, all right, this is where we need to take you. When it comes to preaching the word of God, again, our belief system seems to play a role. Touch not my anointed. If the person, they are not sure, is this God at work here or something else is going on? And as long as it is anything about God, they are not going to be the ones saying something is wrong here. So they would wait until something goes totally offline or expected before they come to the acceptance that this person is ill. The guys have a certain saying. It's not a palatable one, but I want to use it to explain this. They say, "Omanfoseke ayolemla," literally meaning that if the person is family and is showing mental illness, you don't recognize it early. You would ascribe different reasoning. Oh, maybe he's doing this because of that. Maybe he's upset with this and that. So it does not come clearly to them. For those people of the outside, they immediately see a behavior and this is off. But for those who are close, sometimes it takes a little while before they come to that recognition. Sometimes there's a bit of denial. Who wants to admit that my loved one is having this problem? You really wish it's not. So they may be in some level of denial before they finally get there. I think that explains why sometimes there's a long wait.
Another comment, it says, hello, please. My headache is, why should all these facilities and specialists be far from the reach of the ordinary Ghanaian? My secretary did not write your name, but I can tell you that they are not far. Yeah. When you get to every facility in this country, chances are there is a mental health unit in there. There are community mental health nurses in our communities. They are there. You can see them by their uniforms.
Dr. Arthur, I think we need to explain it a little bit to them because most people believe that a mental health facility are just those three, the Accra Psychiatric, Pantang, and Ankafo. But
no,
every hospital, if you go to a Rich Hospital, Lekma, Achimota, 37 Military Hospital, every hospital now does have a mental health team. So you don't have to go to the Accra Psych or the Pantan or Ankafo first. So like Dr. Atta said, they are everywhere around us now.
Thank you very much. Case closed. Does one need to subject a client to a psychometric test in order to diagnose the condition?
Okay. I think that comes into the lap of the psychologists. So let me say that psychometric tests are used for particular purposes. There are some psychometric tests that are used to elicit these symptoms that we have talked about, and the strength of your diagnosis may be pushed by how the person has responded, how many of the yeses, if I should put it simply, are on this test. We know that mental health illnesses are not diagnosed by laboratory tests, okay? But sometimes you're asked to do laboratory tests to exclude other medical conditions that may be mimicking some mental health condition. Psychological or psychometric tests are used to support your diagnosis where you have picked up from your clinical history taking, you get a solid history taking, you just want to confirm, and then you use these psychometric tests to support your diagnosis. So yes, there are some, but you cannot use only a psychometric test to say because the person filled out this way, fine, it is schizophrenia and nothing else. So let's desist from using only psychometric tools to make diagnosis. Assessments go beyond using tools. It starts from a good history taking and is irrespective of which mental health practice area that you are in. Psychiatrists will do the same, psychiatric nurses will do the same, psychologists will do the same. We all will take a good history and do a good mental status examination, some physical examination from the psychiatrist, the mental health nurse, maybe not particularly from the psychologist, but observations made. And then you just use your psychometric test to buttress it. Thank you.
All right, thank you, Erica. Another question says that, so what are the caregivers doing to help family members or the population come to terms to accept and understand what is being discussed? Well, caregivers, I don't think that caregivers are a group in this country. They are in families. Yeah. And so knowledge programs like this are quite helpful to them. They would understand and be able to draw other family members so that their support for them could be heightened. They are not a group, but we encourage them to be able to form groups. The psychologists and the psychiatrists in all the facilities, I think that they are doing that. So if you know of one, encourage them to be part of these groups because it's quite helpful. That way they could be able to draw in other family members to come and support. This question says that, do many families attribute conditions to witchcraft and demon possession under spiritualization? Thank you. Well, in fact, that is what you said. People have superstitious belief about some of these things, but like you are saying, there's the medical background to all these things. Worst case scenario, you need to combine your religious beliefs, going for prayers as well as for medical attention. And like Erica just said, every facility, medical facility, be it a district hospital, be it a regional hospital, be it a CHIPS compound, get in there. There is a mental health unit there. Talk to them. There is no. If you hesitate in seeking for this assistance, the situation will get worse. This person wants to be a student, but I don't know how. What is the effect of antipsychotic medications on an adolescent living with schizophrenia? I think, Maluk, this is down your alley, but I think it should be a quick one.
What's the question again?
What is the effect of antipsychotic medications on an adolescent living with schizophrenia? I am thinking that this person has a family member who is on this condition and they are experiencing some side effects.
Yeah.
And I think that it's worrying them. But I think that if it's worrying you, Maluk, I think that if it's worrying them, they should have a conversation with the specialist taking care of your person. Don't sit at home and get worried. Have a conversation. All of you supporting. Sometimes it could be the support that the individual needs, helping the individual to take the medication, helping the individual to eat well, to keep well, that's social skills. So I would suggest that you have a conversation with your experts taking care of your person here. But I think if Maluk would add something to it.
Yes, rightly so. The effect of antipsychotic on an adolescent who has been diagnosed with schizophrenia. Unfortunately, the one who asked the question didn't provide maybe the symptoms that led to the diagnosis of schizophrenia. So the effect of the antipsychotic would be to take care of the symptoms that the person presented with, to help the person get back to his or her previously functioning level. And it is usually not easy for families when they see their adolescent present with the symptoms. So the effect of that will be that unless you are seeing effects in a negative sense, whereby there may be some side effects, but the psychoeducation would have dealt with that. And as the person comes for the regular follow-up, we deal with all those things that comes up. But the antipsychotic is supposed to help the person get well, get better. That is what it is supposed to do.
Thank you. Okay, this question I just want to raise so that the contributor would know that I've taken notice. Where do we draw the dichotomy between religion and the condition of the schizophrenic condition? I mean, we've discussed this at length. I mean, we are religious people, and schizophrenia has signs and symptoms. So if you realize that, I would say it's better to combine both. Go for the medical support and go for prayers. That's all. Don't dichotomize both of them. You want both, so you can have both. And when you get to the medical center, they will support you. You need to have to combine both in a much better, enhanced way. I missed one. I'm trying to. There's one question which I've already noted down. I'll ask later on. At what age can someone be diagnosed of schizophrenia? And which age groups are mostly affected and why?
Okay.
Erica, can you pick that up?
Yes, please. Studies show that the males are diagnosed relatively earlier, late adolescent, early adulthood. So in your late teens to early 20s, and for the females, usually relatively around that age, but more early adulthood than in their teenage years. So these are the age range at which diagnosis is usually made first, or the disease begins to manifest.
Dr. Atta, just to add on, so you realize that, like we already alluded to, we have the higher male incidence as compared to female incidence, even though we had the reverse from your statistic, because of the earlier age of onset for males. And usually 15 to 25 years seems to be the age range that you have males presenting with. After females, like Dr. Dixon alluded to, 25 to 35 years. But bottom line, late teens, early adulthood, that's when they. But the symptoms can occur at any age range. Just that this is the time that we get more people presenting with the symptoms of schizophrenia.
All right. So, Maluk, hold on to that. Let me ask you one. What is the likely outcome? What is the likely outcome of a person with schizophrenia when all this management and treatment are gone? What is the likely outcome?
All said and done, the outcome can be good if the person presents with the symptoms at a later age, there's enough family support, the treatment was initiated immediately or within a short period of time after the symptoms came with, the outcome is likely to be good. But as we have it, the presentation tends to start early in life, late teens, early adulthood, and this can make the outcome very poor. So if families do not put in the appropriate interventions early, the person doesn't adhere to treatment, etc., etc. And let me just add that the female gender tends to have a better outcome as compared to a male gender, and this could be due to one, the late presentation, two, perhaps they tend to adhere more treatment than the males, etc., etc. But the outcome can be good depending on certain factors. But the onset early on in life can bring about a poorer outcome because it then affects your ability to acquire a livelihood. You're not able to complete school, you're not able to acquire a certificate, etc., etc.
Erica, would you like to add something to it?
Okay, no, I think it's perfect.
Okay, so we're still, as we are educating people, what psychosocial support systems, whatever, are available for the individual experiencing the condition and for family members?
Okay. I think that whilst we're talking about interventions, I did mention that individuals can have some psychotherapy. The family and significant others can also receive some therapy to be able to deal with the stresses of what the family is going through and be able to cope better. Self-management becomes key. So teaching individuals living with this condition to self-manage is important. They recognize the things that would usually trigger them or bring on the symptoms. They know when to take their medication, recognize when symptoms are showing up, and so on and so forth. These are important, and it's important for all illnesses. Again, my analogy, if you have diabetes, for example, it is not just going to hospital and then you are doled pills or injections, go and take this medicine. You are taught what foods to eat, how you should keep physically active. The same way anyone who has schizophrenia, and physical exercise is one of the things that is salient in all mental health care. When you physically exercise, there are brain chemicals that are released that help you feel good. So the person is trained in self-management, is trained in social skills. When you go to other jurisdictions, you may find programs, set programs. Those we don't particularly have, but I know that units try to do their own small programs for their patients. And I think that as we go on, or as mental health grows in our country, we would have good support systems for persons living with all kinds of mental health conditions, including schizophrenia.
All right, thank you. I know that, Erica, it's about time for you to run away. So I know you can run away and come back. We have our arrangement, so I
would do that.
So you can run away now and join us again.
I would do exactly that.
I'll hold the fort with Maluk here.
Yeah, so I just wanted to add on something about the psychosocial support. Support groups for people who have been diagnosed with schizophrenia and also support groups for family members or carers of clients diagnosed with schizophrenia. One way that we can look at helping clients get well, and also to help the carers also support each other. That's something that is gradually taking shape in the country, and I think that's something that we should encourage. In our settings, it's still not easy. You still don't want to identify because of the labeling, but that's something that really helps a lot. Support groups would help, and it does help.
All right, thank you. Rishetu Bato makes a comment here, very educative and interesting. I think the spiritual center should be educated on these issues. Thank you, Rishetu. Emilia, can you let me mute Emilia? Akusika Goka asks a question. My question is, how do you make a person exhibiting symptoms of schizophrenia to understand he or she needs to be on psychotropic meds when they argue strongly that they are not mad? Thank you. Well, Aku, I can say that it is not for you to say that they need to be on the meds. The first step is to seek for help for them. So I would advise that you take them to the hospital. There are specialists, lots of them out there, to see specialists like Dr. Maluk and Erica and others. They are all out there in the facilities. Thank you. Abigail Sapon says, my little sister was diagnosed and it's hard to get my parents to seek medical treatment. My sister believes everyone, including family, is out to harm her. It's hard to take care of her. We are trying our best. Well, like the symptoms that Erica and Dr. Maluk explained, this is one of them. And I don't know how long it's taking, but my suggestion is to convince her, if for nothing at all, a normal hospital, maybe that one should be comfortable to visit, then you can take it up from there. But I suggest that you do your possible best to seek for help for her, because as you wait longer, the condition worsens, and when the conditions worsen, it impacts on the outcomes of the condition. So I would strongly suggest, as you try to convince her to seek for medical help, seek for medical help. Aaron, I've read your question. Jane Wando, I've read your question. Caleb, I've read your question.
There's a question about concoctions. I don't know that you've gotten to that yet.
Is this the last one that just came in?
Okay.
Yes, okay. From Ketri, does concoction given at the various camps have any effect on drugs given at the hospital? If it does, how do you blend both the medical treatment and traditional healing, since those at the camps may not simply give much attention to medical treatments, which they see as a source of making money? That's quite an interesting topic there. Maluk, Dr. Maluk, would you like to respond to that? But I'm thinking that traditional and faith-based healers that we have engaged with, they do not, for the sake of the medication, they are interested. They've come to understand. They come to understand the scientific basis of the condition. So what they do is to provide that psychosocial support for this individual, while the hospitals provide the medication. There is no blend, that I can tell you.
And now we even have the faith-based healers. They asking them, I've had a number of clients tell them that they first went to a prayer camp. The pastor said, please go to the hospital first. And when you are well, you can come back to me.
Fantastic. So that is what is going on.
It does happen. Of course, for places whereby they may give some concoctions, there may be certain interactions, but really for the faith-based, I know that they usually ask them to come to us,
Yeah. So, Kachi, this time, those that we have engaged with are becoming more supportive in their collaboration. They understand which points that we are going. It's not always about money. Also,
we have a lot of questions so in the chat, so many questions in the chat, or so many comments.
Yeah. I see the last one. How do I get a copy of this video of this seminar? Mr. Sowa, you can remind me later on and I'll let you. We are recording it, so we'll have them on our Facebook page, Mental Health Authority Facebook page. It will be there. We have all the seminars that we have done is on our Facebook page. You just click on the link and you will have access to them. And this one will also be part of it, hopefully by next week. Jones, Kwesi, if a client refuses treatment, if even at the point of no insight, what should the practitioner do, taking the WHO quality rights into consideration? Dr. Malik, will you take that?
So for every country, we have laws that govern what we do. In Ghana, our most recent law on mental health is the Mental Health Act 2012, Act 846. It also has the legislative instrument, the Mental Health Regulations 2019, LI 2385. This spells out what you do in some of these instances or situations. And as Dr. Atta, I'm sure you know, we have the, there's a section, I think that should be section 40, or that's just about the involuntary treatment. And there are ways to go about it. So be rest assured, this new mental health law, which came into being in 2012, factors in clients' human rights into it and ways to go about it so that it will protect you and me, because any of us can come down with one mental disorder or the other.
All right, thank you. Elizabeth, she says, what if the schizophrenic patient, Elizabeth, that is what we don't say.
Labeling.
That is what we don't say, a person with schizophrenia. You are labeling even your patient. That is a stigmatizing way. So say a person with schizophrenia, that is more appropriate. Now, to your question, what if a person with schizophrenia refuses to take his or her medication? What can be done as caregiver to help him to take medication? Also, what can be done when the person begins to ignore his personal hygiene, for example, refusing to brush his teeth, take his bath, and all that? As a caregiver, I suggest that when you go for reviews, these are some of the concerns that you raise. The specialist will give you ways and means that you can address some of these things. It's all part of the psychosocial support. There are nice and simple ways of doing some of these things. Oh, Dr. Maluk.
Yeah, right.
Okay. Dr. Maluk, how long do you treat a person with schizophrenia? How long would the treatment last?
An often asked question. So once again, once you are sure you've made the correct diagnosis, I keep insisting on that because you've got to really assess. It's not easy to label someone as having schizophrenia. It comes with it with a lot of ramifications. So once it's schizophrenia, we know it is a chronic condition. But the natural history or the natural cause also come into play. 1/3 of people that know schizophrenia would usually go into spontaneous remission. 1/3 who will be on treatment along the way may have remissions and relapse or the 1/3 goes into a chronic state. Treatments with medications, 2 schools of thought for life. So some also say treat for 5 years and then begin to wean the person off. In our setting, where a client you've diagnosed met all the criteria for schizophrenia, start on treatment, the person begins to improve, functioning gets back, able to start going to work. After 2-3 reviews, the person stops coming for review, goes off medications, family looks on. A year down, 2 years down the line, the person relapses, neglecting personal hygiene, wondering about, etc., etc. Family brings back. So it makes it a problem to even eventually take the person off, Yeah.
All right, thank you. I see Dr. Joanna. Joanna, are you on? I see Dr. Joanna. I would want her to give her. Joanna, can you hear me? Joanna Larry. Unmute yourself. Oh, she cannot hear me. I wanted Emma to give us what she thinks so far. I see two last questions. Let me see if I can quickly go through them. Aaron Apia says, would like to know if there is any herbal facility in the country is accredited to assist in this fight. If not, what is the mental health authority to fight or to help someone, to help some of these herbal centers? Aaron, I do not get your question. I do not, it's not too clear. Sorry about that. It's not too clear. We are out of time by 10 minutes. Dr. Maluk is also another very busy person, so that we'll have to bring the conversation to an abrupt end. But I might say that this has been a very insightful and interesting program. I mean, we now clearly know the signs and symptoms of the condition: hallucination, delusion, cognitive impairment, behavioral impairment,
lack of drive, etc., etc. Lack of drive
and all that.
Decline in functioning.
And all that. Ladies and gentlemen, when you see that, as soon as possible, seek for help for this individual. We have our beliefs, our religious beliefs. Yes, it's part of the management process. So don't separate that from the medical treatment. We advise that you combine both. When you go to see the specialist, they would assist you to combine both. In actual fact, there has been several interventions in Nkranza and there whereby they are combining both, and recovery rates are much higher, and they come out well. There are strategies to provide psychosocial support. Family members must support the caregiver. That way, it improves the outcomes of this individual. I want to thank all our participants here. It hit about 130. Some have dropped off, but I want to thank all of you for being part of today's program. We are hoping that as you have joined us, you will send the knowledge out there. You would help people to understand that yes, the experts say that their beliefs is understood, but they need to combine that with the medical support. So we thank you for being part of today's program. Dr. Maluk and Dr. Erica Dixon, we cannot thank you enough. We cannot thank you enough. As always, you're always there. When we call them, they don't say no. They say, yes, we are happy to be part. We want to say a very big thank you for being part of today's program. On that note, ladies and gentlemen, God willing, if you have life, we are in good health. Same time, we will have another seminar. I saw a lot of friends, Eric, Ledina, Paul Sowa, Dr. Joanna, Larry Afutu, Felicia, Christabel. Christabel was eating all through the program. Our chief pharmacist, Felicia, I see you. Laura, Modesta. Thank you also. Oh, Colonel Suleiman, I also see you there. Haji Gifty. In fact, I thank you all. Olivia, thank you all for being part of today's program. Have a very fruitful and a nice weekend. God bless all of us. Bye-bye for now.
Bye-bye. God bless. Bye.